Hello everyone. After completing the drugs used in Parkinson's disease, now we move on to antipsychotic drugs. Okay, if you have understood the how Parkinsonism occurs and how the drugs they work against the Parkinson's disease, or how the anti-Parkinsonism drugs work, okay, then you'll have a very easy time understanding about antipsychotic drugs. Okay, let's first see few points about schizophrenia. Okay, so in schizophrenia basically there are two types of symptoms. Okay, one is positive symptom and one is negative symptoms. Okay, so the positive symptoms of schizophrenia, they are thought disorders, delusions, hallucinations and paranoia. Okay, and the negative symptoms, they include decrease in motivation or amotivation, social withdrawal, flattening of affect and poverty of speech. Okay, so there are few hypotheses uh, that have tried to explain how schizophrenia occurs. Okay, basically the first one was dopamine hypothesis. Okay, it according to this dopamine hypothesis, this schizophrenia occurs due to increase in dopamine inside the central nervous system. Okay, and recently the effect of serotonin. Okay, the this serotonin is increasingly seen as a part of etiology of schizophrenia. Okay, so the serotonin activity. So remember these two things, that this dopamine, increase in dopamine and increase in serotonin levels. These two are very crucial in causing schizophrenia. Okay. Okay. Let's see. Okay. Uh, okay. So. mm, okay. So let's see. So if someone is having schizophrenia, okay, so what should the pharmacological strategy be in controlling the symptoms? Okay, so since this schizophrenia occurs due to increase in dopamine and increasing in serotonin, that is 5-2, it is obvious that blocking their action will help in the treatment of schizophrenia. Okay, so one is you block the dopamine receptors, second is you block the serotonin receptors. Okay, basically you're blocking the action of dopamine and you're blocking the action of serotonin. Okay, uh, just for an example, okay, just to make it easier to remember, that the positive symptoms, they are usually due to stimulation. Okay, stimulation effect. So what you do, you depress those. Okay, if a person is being paranoid, if hallucinations are occurring means something inside the brain is getting stimulated, mainly in the mesolimbic system. So what you do is you depress those. Okay, and negative symptoms are due to depressive effect. Okay, and what you do is you do stimulation. Okay, this is for just for easy understanding. Okay, so this is the pharmacological strategy behind using behind the use of these drugs. Okay, the drugs that alter the dopamine and serotonin levels inside the brain in treatment of schizophrenia. Okay, okay, and now another important point is these positive symptoms, they're usually due to dopamine, increased level of dopamines. Okay, so the treatment logically would be to provide dopamine antagonists. Okay, and the negative symptoms, they are usually due to serotonin, so the logical treatment would be serotonin antagonism. Okay, so this was just a brief I was just giving you brief points about how to understand what's going on and how we approach the treatment. Okay, next I think we'll discuss about. Okay, nope, nope. Okay, next we'll discuss about actions due to dopamine receptor activation. Okay, if you remember this from the excuse me, if you remember these points from the anti-Parkinson's video, then it will be very easy. Okay, if you remember these points, then you will have very easy time understanding the side effects of these drugs used in schizophrenia. Okay, so first, activation of dopamine receptors, it helps in Parkinsonism. Okay, so we use dopamine receptor agonist for treatment of Parkinsonism. Okay, so this will come while we discuss about the side effects. Okay, since we are giving dopamine receptor antagonist, then these drugs, they might produce pseudo Parkinsonism effect. Okay, we've already discussed about the positive symptoms like increased risk, reinforcement, psychosis. Okay, due to dopamine activity. Okay, and third point is that stimulation of dopamine receptors or increase in the dopamine content in the brain, it decreases the secretion of prolactin, since dopamine itself is prolactin inhibiting factor, and it will also decrease the growth hormone secretion. So logically, if you are giving dopamine receptor antagonist in the treatment of schizophrenia, then what happens is, due to decrease in prolactin, certain side effects like gynecomastia, due to increase in prolactin due to dopamine receptor antagonist, what happens that due to in male gynecomastia is seen, and in female amenorrhea is seen. Okay, the fourth one is weight loss and anorexia. Okay, these are due to dopamine receptor activation. Okay, remember, so if you are giving agonist, if you are giving dopamine receptor antagonist, then what happens is that there occurs weight gain. Okay, and increase in hunger. So opposite action. Okay, these are due to activation of receptors, activation of the dopamine receptor. So opposite action will occur as a side effect. Okay, the next is emesis. Okay, by the activation of these dopamine receptors in the chemoreceptor trigger zone, vomiting can occur. And if we are giving dopamine receptor antagonist, then what happens is that it will act as an antiemetic. For example, drugs like metoclopramide, they act centrally, they block the dopamine receptors and are used as an antiemetic. So okay, let me write it. So these are used as dopamine receptor antagonists, they are used as antiemetics. Their side effect is weight gain. Okay, and their side effect is increased prolactin causing gynecomastia and amenorrhea, and this other. Okay, next we'll move on to a bit deeper into the side effects. Okay, these are the actions due to dopamine receptor activations. Next we'll discuss about the side effects of these antipsychotic drugs. Okay, so the first one is dyskinesias, or also called extrapyramidal side effects, or EPS. Okay, these are of two types. Okay, remember I told you that dopamine agonist or activation of dopamine receptor, that it helps in Parkinson's disease. But if you are blocking the dopamine receptor, or if you are decreasing the dopamine content in brain, then you will have problems with movement. Okay, so means this drug can create a stage of pseudo Parkinson's. Okay, so dyskinesias, they are basically two type: acute and chronic. Okay, acute one is pseudo Parkinson's. Okay, I've already explained this. And the next one is dystonia. Okay, excuse me. This dystonia, it can present as torticollis. Okay, torticollis, muscle rigidity, torticollis of the neck, thus making it very difficult for you to move your neck, and it is also painful. Okay, so what do you give as a treatment? You give anti-muscarinic drugs. Okay, suppose that if you're giving dopamine, okay, you are supplementing dopamine to treat this, nothing is going to happen, because these antipsychotics, they have anti-dopamine, dopamine receptor antagonist feature. So the only treatment is giving anti-muscarinic agents. Okay, this means benzhexol, triexphenydyl. Okay, so the next one is chronic extrapyramidal side effects. Okay, these most importantly include the tardive dyskinesias. Okay, tardive usually referring to long term or chronic. What happens is that once you are giving these antipsychotic drugs for a longer time, we'll discuss about which drug will cause this tardive dyskinesia more. But let us first see the mechanisms. Okay, if you are giving these drugs for a long time, what happens is that you are blocking the dopamine receptors. Okay, you are blocking the dopamine receptors. What happens is that if this goes on for a long period of time, those receptors that are not blocked or that are free from the dopamine antagonist, they become hypersensitive. It is called sensitization of receptors. Okay, so even if a little amount of dopamine comes there, it will cause akathisia initially. Okay, akathisia means feeling of restless. Okay, the person cannot sit at a place and has a desire to move around. Okay, akathisia. So even little dopamine will stimulate this hypersensitized receptor and it will cause akathisia. Okay, later what happens, these receptors are sensitized also, and the body will naturally increase the number of these receptors, that is upregulation of receptor will occur. Okay, so this will result into tardive dyskinesia. Okay, this tardive dyskinesia, it is characterized by involuntary movements of mouth, tongue, and the upper limbs. Okay, the patients, they want to control it, but they cannot. Okay, their tongue, their mouth, their upper limbs, they move spontaneously and involuntarily. Okay, suppose if you increase the dose of antipsychotics in a patient having tardive dyskinesia to control these symptoms, what if a person has developed tardive dyskinesia due to antipsychotic drugs, and if you increase the dose of these antipsychotics again, it will cause more upregulation of these receptors. Okay, thus increase in the sign and symptoms. And remember that these changes in tardive dyskinesias, they are often irreversible. Okay, we'll discuss about which drugs will are more likely to cause tardive dyskinesias later. So the treatment is you discontinue the drugs and or switch to atypical antipsychotics, meaning that the typical antipsychotics are very famous for causing the extrapyramidal side effects, mainly haloperidol and flufenazine. Okay, so the next side effects is dysphoria. Okay, dysphoria means worsening of the negative symptoms due to dopamine blockade in mesolimbic area. Remember that dopamine receptor in the mesolimbic areas, when they are activated, they give you a sense of reinforcement. Okay, so if you are blocking this, then you are causing worsening of those negative symptoms. Okay, so this is dysphoria. Okay, next is increased prolactin. I've already discussed about this. It will cause gynecomastia and amenorrhea. Okay, the next is weight gain. Again, I've already discussed this in when we discussed about what happens when the dopamine receptor is stimulated. Okay, mainly in the hypothalamus. Okay, mainly in the medial and lateral nuclei of hypothalamus. Excuse me. Stimulation of the dopamine receptor will cause anorexia and weight loss, and antagonism will cause weight gain. The next is neuroleptic malignant syndrome. Okay, temperature regulation problems. Okay, what happens is that in neuroleptic malignant syndrome, suppose dopamine in hypothalamus, it usually controls the thermoregulation, that is the temperature thermostat. So if you are blocking the dopamine receptor, it can mess up that temperature regulation, and it will result in hyperthermia. So how do you treat this? How do you treat this neuroleptic malignant syndrome? You give dantrolene sodium and Bromocriptine. Okay, bromocriptine, dantrolene sodium, and obviously supportive measures. So then, okay, now the sixth side effect is usually due to muscarinic blockade. Okay, due to muscarinic receptor blockade, it will cause tachycardia, and it will cause decrease in seizure threshold. So, if the drug is blocking the muscarinic receptor more, then it is more likely to cause convulsions. Okay, the seventh is due to alpha receptor blockade. Okay, remember that dopamine at low doses. Okay, I'm not talking about dopamine antagonist. I'm talking about dopamine. Okay, dopamine itself and dopamine antagonist. Dopamine at low levels, it will stimulate dopamine receptors, and as you further increase the dose, it will stimulate beta receptors, then it will stimulate alpha 1 receptors. Okay, so dopamine will at higher doses stimulate alpha 1 receptor, causing vasoconstriction. So the opposite action of this dopamine antagonist will be alpha blockade and causing hypotension. Okay, these 2 points, number 6 and number 7, okay, these are quinidine like effects. Okay, but as seen with quinidine, no kinkonism or chinkonism is seen with this dopamine receptor antagonist. Okay, okay, let's now see the types of antipsychotic drugs. Okay, so basically these drugs are divided into two types, mainly on the basis of mechanism of actions. Okay, so the first one are typical antipsychotics. Okay, their main action is that they mainly block D2 receptors in mesocortical and limbic areas, thus okay, thus causing antipsychotic effects. Okay, so D2 blockade in the mesocortical and mesolimbic areas. Okay, the second one is atypical antipsychotics. Okay, their main action is that they have 5-HT2 blockade with weak D2 receptor blocking effect. Okay, remember that I told you that the positive symptoms, they are usually due to dopamine, and if you give dopamine antagonist, then it will help with the positive symptoms, and the negative symptoms are usually due to serotonin, and the serotonin antagonist will help. Okay, remember that the stimulation of these 5-HT2 receptors or serotonin receptors, they have similar actions as that of presynaptic alpha 2 receptors. Okay, so if you are stimulating these receptors, it will cause decrease in serotonin release, and it will cause stimulant effect. Since serotonin is causing negative effect, that is depressive effect, so decrease in the serotonin levels due to stimulation of these alpha 2 receptors will cause stimulant effect. Okay, next we'll discuss something about, next we'll see a few of the typical antipsychotic drugs. Okay, then we'll move on to atypical antipsychotic drugs. Okay, so forgive my handwriting. Okay, I had only this much space to write into, so we'll discuss mainly about these four drugs. Okay, chlorpromazine, thioridazine, flufenazine, and haloperidol. As you can clearly see that the number of pluses, plus sign, they indicate how much effect these drugs they create. Okay, so the EPS is the extrapyramidal side effect, M is muscarinic blockade, SE means sedation, and alpha blockade, this is alpha blockade, and any other miscellaneous effects that these drugs they might have. Okay, so how to remember these? Okay, these first two, this chlorpromazine and thioridazine. Okay, see that these two have uh, great muscarinic receptor blockage, great sedation, and great alpha blockade. Okay, so likely similar. Okay, so chlorpromazine and thioridazine, they have greater muscarinic receptor blocking activity, greater sedation, and greater alpha blocking effect. Okay, and these last two, flufenazine and haloperidol, they have more of extrapyramidal side effect, but other effect like muscarinic blockade, alpha blockade, and sedation, they are relatively less. Okay, this is how I remember these. Okay, so EPS is due to flufenazine and haloperidol, and other three effects are due to chlorpromazine and thyroidazine. Okay, are more seen in those two drugs. Okay, so the one important thing about this drug thyroidazine is that it acts as an this drug, it has cardiotoxic effect, that is quinidine like effect. Okay, remember that this drug thioridazine has cardiotoxic effect. It can cause torsades. Okay, and the next one is that it can also cause retinal. Okay, so let me draw an eye here. It can cause deposits in the retina. So this is cardiotoxic, and it can sometimes cause retinal deposits. Okay, and one important thing about haloperidol is that it is the most likely agent to cause neuroleptic malignant syndrome and tardive dyskinesias. Okay, so if you are prescribing haloperidol to someone, keep in mind that these persons may land up into neuroleptic malignant syndrome and tardive dyskinesias. Okay, so I think these are the important features about these typical antipsychotic drugs. Remember that their main action is blockade of the D2 receptors in the limbic system and the mesocortical areas. And remember, chlorpromazine and thyroidazine, they have mainly muscarinic blockade. They have greater muscarinic blockade, sedation and alpha blocking effect, and this flufenazine and haloperidol, they are more likely to cause extrapyramidal side effects. Okay, next we'll discuss about the atypical antipsychotic drugs. Uh, we'll now see about the atypical antipsychotic drugs. Okay, basically about the drugs clozapine, olanzapine, risperidone, and aripiprazole. Okay, again we have used this format. Okay, uh, remember that these drugs, atypical drugs, they mainly have 5-HT2 or serotonin receptor blocking activity with weak D2 receptor blockade. You can see that most of these drugs, okay, they cause minimal extrapyramidal side effects. Okay, this clozapine, it has some muscarinic receptor blockade activity, and it can cause huge alpha receptor blockade, alpha receptor blocking activity. Okay, so these other points, in these other points about clozapine, these are very important. Okay, remember that the clozapine will block D2C receptors. Okay, remember we discussed in the beginning of the anti-Parkinson's drug that these D2C receptors, they are present in mesolimbic and mesocortical areas, while the receptor D2A, they are present in nigrostriatal pathway. So, so uh, no blockade of D2A receptors, therefore no effect on the nigrostriatal system, therefore no tardive dyskinesias. So these drugs, it does not cause tardive dyskinesia. Okay, so about clozapine, okay, I'll write it separately here. Okay, clozapine. So one important is no tardive dyskinesia. Another important one, let me change the color for this one, and always remember this agranulocytosis. Okay, this is very dangerous side effect of clozapine that has decreased the use of clozapine dramatically. Okay, so if you are prescribing clozapine to someone, you will have to monitor the WBC count weekly. Okay, so this is the second point about clozapine. The third point is that it can cause something called the wet pillow syndrome. Okay, it is due to excessive salivation. So wet pillow syndrome, this is due to excessive salivation. It is due to serotonin. Okay, not due to any other receptors, but it is due to serotonin. Okay, and lastly, due to this muscarinic receptor blockade activity, blocking activity, it can cause seizures. Okay, it will decrease the seizure threshold, therefore can result in convulsions. Okay, so basically due to this agranulocytosis side effect, the use of clozapine has dramatically decreased. Okay, so the second drug is olanzapine. Okay, it is a very commonly used atypical antipsychotic drug. Okay, so it causes less extrapyramidal side effect, it causes less uh, effect on muscarinic receptor, less sedation, and it has some alpha blocking activity. Okay, so the important point to remember about this close up olanzapine is that it blocks the 5-HT2 or serotonin receptors, thus improving the negative symptoms. So negative symptoms are improved. Okay, so this was about olanzapine. Okay. Okay. uh, okay, so remember alpha blocking action will cause hypotension. Okay, the third one is risperidone. uh, it has similar properties in this section, in the other section, similar to olanzapine, that is blockade of 5-HT2 receptor and improving of negative symptoms. Okay, so this, it can also cause hypotension, can also cause sedation. And the last one is aripiprazole. Okay, important thing about this is that it is a partial D2 agonist and also has 5-HT2 receptor blocking activity. So agonist on partial agonist on the D2 receptor and serotonin receptor blocker. Okay, so if you are giving someone risperidone, then what can happen? Sorry, if you are giving aripiprazole, then think about this partial dopamine uh, agonistic effect and blockade of 5-HT2 or serotonin receptor. Okay. One thing about risperidone is that it increases prolactin levels. Okay, so people may present with gynecomastia, galactorrhea, or amenorrhea. Okay. Next we'll discuss something about something not. Next we'll discuss about the therapeutic uses of these antipsychotic drugs. Okay. So the first therapeutic use is schizophrenia. Schizophrenia. Okay, we have already discussed about this. Okay. Next is mania. Okay, so acute mania, it can be treated with neuroleptics. Okay, these are chlorpromazine or haloperidol, and generally the lithium is used later for maintenance therapy. Okay, atypical antipsychotics like olanzapine, risperidone, and aripiprazole are also commonly used for the treatment of acute mania. Okay, lithium is not preferred in acute phase because of its slow onset of action and narrow safety margin. Okay, it requires measurement of blood lithium levels in regular basis. Okay, mania, and the third use is in as an antiemetic. Antiemetic. Okay, by the due to blockage of D2 receptor in the chemoreceptor trigger zone. Okay, the next one is in intractable hiccup. Okay, generally the drug chlorpromazine, it is used in the treatment of intractable hiccup. So I think this concludes about the antipsychotic drugs. We discussed how this drug works and what are the side effects, what are the uses of these drugs. Okay, okay, let me again add something. These drugs are used in schizophrenia, schizoaffective states, bipolar disorder. Okay, bipolar disorders. Okay, and in Tourette syndrome. Okay, Tourette syndrome and Huntington's disease. Okay, so Tourette's, Toure, Tourette syndrome and Huntington's disease. Okay, I think now this concludes the antipsychotic drugs. Okay, bye bye.